In a first-of-its-kind decision, the Alabama Supreme Court has ruled that frozen embryos are children and that a person can be held liable for destroying them.
I do think that if you look in the definition, an embryo is considered an unborn baby.
As an embryo, do you feel like you're like a full human life?
Does this look like a life to you, Colin? I'm living at negative 200 degrees in liquid nitrogen.
My husband and I have been trying to expand our family for the last 3 years.
Behind every policy debate, there are people. Couples and individuals who have spent months or years trying to become parents. For some, that journey includes medications, appointments, and procedures, steps that can eventually lead to the miracle of life. But for so many, they never even get that chance. Cost, insurance, geography, and state laws make treatment, including IVF, out of reach before their journey can even begin. To understand why access matters so deeply, it's important to understand what IVF actually is. In vitro fertilization, or IVF, is a medical process where eggs and sperm are combined outside the body, and an embryo is then transferred into the uterus. For people facing infertility, genetic conditions, or same-sex couples, IVF may be the only path to having a biological child. But IVF is expensive, often $15,000 to $25,000 per cycle, and most people need more than one cycle. Insurance coverage also varies dramatically by state. Most states don't cover IVF through Medicaid, and only a handful, like Illinois, Massachusetts, and New York, require private insurers to cover any part of fertility treatment. Everywhere else, families are left to pay entirely out of pocket. That means access to the chance to build a family can depend more on your zip code than your medical needs. And while Alabama's Supreme Court ruling grabbed national attention in 2024, the truth is that access to IVF has been a challenge long before that decision, and has always depended heavily on state policy. Alabama simply made the issue impossible to ignore. But to narrow in on a specific state, it's imperative that we look to North Carolina. The specific policy problem in North Carolina is that Medicaid does not cover infertility services or IVF at all, creating a two-tiered system where wealthier residents can pursue treatment, while low-income families are denied the same chance to build a family. And this matters because infertility is not rare. It affects roughly 1 in 6 people, including the 3 million North Carolinians who rely on Medicaid. And with a median household income in North Carolina of roughly $69,000, the average $21,000 cost of one IVF cycle represents nearly 1/3 of annual income for a typical North Carolinian family. But as you can see, that number also hides major disparities. Asian and white households make far more than the state average, while Black, Native, and multiracial households make significantly less. So if you can't afford it, you simply don't have the choice to try. And the striking reality is that childbirth costs about the same as infertility, at $21,000 for OBGYN visits, delivery, and postpartum care. Medicaid in North Carolina covers nearly $14,000 of that on average, while excluding every part of infertility diagnosis and treatment. Also, Medicaid covers about 50% of all births in North Carolina, so they already spend comparable amounts helping people give birth, but not helping them conceive in the first place. Denying infertility care, therefore, doesn't just create a gap in health coverage, but creates a fundamental inequity in who gets to build a family. To understand what fairness requires in North Carolina's infertility policy, it is helpful to begin with several different justice frameworks. One influential modern approach comes from political philosopher John Rawls, who argued that fair policies are those chosen from an original position, where individuals do not know their income, health status, or social advantages. From this standpoint, most people would choose a system in which the ability to build a family is not determined by wealth or luck. Under this framework, infertility treatment should not be accessible only to those who can afford it. Another foundational perspective is utilitarianism, associated with thinkers such as Jeremy Bentham and John Stuart Mill. This framework evaluates policies by their impact on overall well-being. Infertility is linked to significant emotional and psychological burden, and treatment can dramatically improve quality of life. Expanding access to infertility services increases total well-being by enabling more individuals to pursue the deeply meaningful goal of building a family. But alongside these classical theories, this documentary turns to a more contemporary justice framework, one developed by a young emerging philosopher, Ria Jain of Duke University. This perspective is known as autonomic libertarianism. Autonomic libertarianism begins with the principle of self-ownership. Every individual holds meaningful control over decisions involving their body, their autonomy, and their future. Within this framework, genuine bodily autonomy includes the ability to decide if, when, and how to build a family. Reproductive choice is understood in both directions. Justice requires autonomy not only in preventing pregnancy, but also in creating a family when natural conception is not possible. This framework builds on two major themes seen throughout justice history. One theme emphasizes personal freedom and bodily autonomy, central to many libertarian and autonomy-centered traditions. The second emphasizes fairness as the removal of arbitrary barriers that prevent individuals from exercising meaningful choice. Together, these principles support a view of justice that protects freedom, while recognizing that autonomy must be supported by actual practical access to the choices it promises. Through the lens of autonomic libertarianism, North Carolina's Medicaid exclusion of infertility services is fundamentally unjust. Medicaid in North Carolina covers contraception, pregnancy, childbirth, and postpartum care, but by excluding infertility diagnosis, medications, and IVF, it goes against autonomic libertarianism. Preventing pregnancy is supported, and building a family is not. This imbalance reveals a deeper moral problem. Reproductive autonomy requires equal respect for family creation and pregnancy prevention, yet only one is accessible to low-income residents. The central question, then, is not whether family building matters, but whether every person should have the same right to pursue it, regardless of income. Under autonomic libertarianism, a just system would expand Medicaid to include infertility services, ensuring that reproductive autonomy does not depend on wealth, geography, or insurance status. If justice requires reproductive autonomy, the next step is determining what specific actions North Carolina can actually take to correct the inequity created by Medicaid's exclusion of infertility care. And so, there are 3 recommendations that North Carolina should consider to fix and better its Medicaid policy when it comes to infertility. The first and most ideal would be North Carolina amending its Medicaid program to cover infertility diagnosis, medications, and multiple IVF cycles. The second recommendation would be to expand Medicaid to cover infertility diagnosis and at least one IVF cycle. And finally, the third recommendation is North Carolina covering fertility preservation for patients whose cancer treatment is likely to impair fertility. The first and most comprehensive recommendation is to expand North Carolina Medicaid to cover infertility diagnosis, medications, and multiple IVF cycles. In terms of action steps for this, it would include the North Carolina General Assembly to authorize Medicaid coverage for infertility services, the North Carolina Department of Health and Human Services to submit a state plan amendment to the Federal Centers for Medicare and Medicaid Services, or CMS. And finally, CMS would provide federal matching funds through FMAP, which covers about 60% of cost. In terms of feasibility, this option does carry the highest cost and faces legitimate budget constraints. Because IVF and diagnostic procedures are expensive, full Medicaid coverage would require a substantial state investment, and so legislators who are cautious about expanding Medicaid scope or cost may view this option as financially difficult in the short term. However, at the same time, Medicaid already funds childbirth costs comparably to infertility treatment, and federal matching funds reduce the state's financial burn. With New York and Illinois already demonstrating that Medicaid infertility coverage can be implemented without destabilizing budgets, it is feasible. And while costly, this option is the most aligned with reproductive autonomy and long-term fairness. If this first recommendation is not feasible, the second recommendation would be a partial Medicaid coverage, so that would cover diagnosis and one IVF cycle. In terms of action steps, we would 1. Create a limited benefit package, and so the General Assembly would authorize Medicaid to cover diagnostic testing and one IVF cycle. Second, we would set clear clinical eligibility criteria, where the North Carolina Department of Health and Human Services defines which patients qualify, ensuring the benefit serves those with documented medical infertility. And finally, submit a targeted state plan amendment to CMS. The state would formally add this cap benefit to Medicaid and receive federal matching funds. In terms of feasibility, this option is significantly more affordable than full coverage, and therefore more politically realistic. If Recommendation 2 remains too expensive for North Carolina, the bare minimum would be the third recommendation, which covers fertility preservation for cancer patients. In terms of action items, the first would be to add fertility preservation as a Medicaid-covered service. The General Assembly would authorize coverage for procedures such as egg and sperm freezing when medically necessary due to chemotherapy or radiation. The second step includes integrating referrals into oncology care, where the North Carolina Department of Health and Human Services coordinates with major cancer centers so eligible patients are informed early and referred before treatment begins. Finally, the North Carolina Department of Health and Human Services submits a focused state plan amendment to CMS to officially add fertility preservation as a covered Medicaid benefit. This is the most politically viable and lowest cost recommendation. It affects a small, clearly defined group and carries broad bipartisan moral appeal. Illinois Medicaid already covers fertility preservation, showing that implementation is feasible and sustainable. Any policy proposal must confront its strongest objections. To do this, we turn to an expert, Dr. Stephen Young of Duke University, a fertility specialist and head of the Reproductive Endocrinology and Infertility Division at Duke Fertility Center. His work stands at the intersection of medicine and policy, showing what is medically possible when cost and coverage barriers are removed. Interviewing him is emerging philosopher Ria Jain. When North Carolina lawmakers push back on expanding infertility coverage, what do you think is the strongest counter-argument?
So I think there are a number of misconceptions that lawmakers have. One is that fertility is not an important part of healthcare. That if someone is unable to have children, well, that's the way it is. It's fate, God's will. I think another misconception that they have is it would be incredibly expensive. But my guess is even partial coverage would allow a lot of families to access care that they cannot access now.
Dr. Young was absolutely correct. As he said, the most common argument against expanding North Carolina Medicaid to cover infertility services is cost. Critics argue that Medicaid should focus on what they see as essential health services, emergency care, primary care, and childbirth, rather than infertility treatment. From this perspective, adding IVF or related benefits would strain the Medicaid budget and take resources away from urgent, life-saving care. This position is rooted in a different justice framework, classical libertarianism, which emphasizes limited government, minimal public spending, and a narrow definition of state responsibility. Within this framework, publicly funded healthcare is expected to remain tightly constrained, and infertility treatment is seen as a deeply personal desire, but not as a public obligation. Autonomic libertarianism reaches a different conclusion. Instead of defining autonomy only as freedom from government interference, this framework defines autonomy as meaningful control over one's body and future. Reproductive autonomy involves both preventing pregnancy and building a family, and North Carolina Medicaid already funds one entire side of that spectrum. Moreover, the cost argument rests on assumptions that do not fully align with reality. Medicaid already funds childbirth at an average cost similar to infertility treatment. Transparent cost comparisons show that expanding infertility coverage would not require disproportionate new spending. Dr. Young also weighed in on this topic.
So there's a lot of things that we can do to make what we do more cost effective. Is we can inexpensively treat, especially younger women who have certain disorders without IVF very successfully.
It is also important to recognize that access to infertility treatment is not a partisan issue. Infertility affects families across the political spectrum, from rural communities to conservative districts and military families. According to a Pew Research Center survey in 2024, they found that 70% of Americans across party lines agree that having access to IVF is a good thing. The desire to build a family is universal, and no one should lose that opportunity because of income.